Hi, good afternoon, everyone. Thanks for joining us for teaching this week. We're just going to go through a whole bunch of cases, if that's okay, and we'll try and stick to time as best we can. And I'll start off, if I may, with myself, and then we've got Louise Cole, one of the other ICU specialists who works here at Nepean Hospital, is going to go through a case or two, and we've got Anne-Marie, our Echo Fellow, who's going to present another couple after that. So I'll start with me. Why don't we start with... I think this is the right one. Yeah, nice. So Ben, do you want to kick this one off? Because this is...
Yeah.
So this is we'll start off with this patient and this is all about clinical context, I guess, and that's sort of the learning point of this case. So if I told you that this lady is... So this lady's come in, she's just had some abdominal surgery, and this is less than 24 hours after the abdominal surgery, which I think was after removal of a mass, and she's fallen into a heap with some peritoneal soiling, and she's now got horrific septic shock. So you'll see from the screen here, a couple of years ago we did this, but she's on double strength noradrenaline at 13 mils an hour, so that would be 26 mics per minute. Sorry, no, it'd be more than that. And she's vasopressin as well at 1.2 mils per hour, and horrific septic shock. So she's got a lactate that's gone up, she's got escalating inotrope requirements, she's got a MAP of 78, and so 6 milligrams in 100 mils of noradrenaline, so a good dose of noradrenaline going. Talk to me about what you're seeing. So that's the reason for the echo.
Yeah, so I'm looking at a parasternal long axis. I think the first thing that I would think is that in light of all the support she's on, it's difficult to make appropriate comments on how everything's moving, how a ventricle's contracting. That's because I would expect it to be contracting vigorously, which
fantastic,
like it is.
And that's absolutely right. So I don't think you should say it's difficult to do. I think it's difficult to... I think it might be difficult to give the exact clinical context about how everything's going. Maybe the exact, say we wanted to try and talk about if she needed a valve replacement, how to interpret ejection fraction in this circumstance in those regards is difficult.
Yep.
But it's not difficult to say exactly as you just said, that you expect the heart to be working much, much better than it is currently, given that level of support.
Yeah, absolutely.
So completely right. So what could be the reason for that? Just take me to the next thought process.
Okay. Well, going off the history that you've told me already, I mean, if she's underfilled, I would think that could lead to a similar picture.
Yeah.
Just from distributive shock associated with the sepsis. I mean,
what do you think a diagnosis is for this bad left ventricle, given the fact that she's, so she's not super old, she's 63. So I've changed her date of birth, but it's still the same year.
Yeah.
So what does that make her? 57. So she's not very old, but she's got a really bad heart with that story of a septic soiling in the peritoneum from the surgery.
Yeah. So, I mean, it could all be sepsis associated. Everything's
septic cardiomyopathy. So we talked a little bit about this last week. So what's the problem with that? What else could it be if it wasn't a septic cardiomyopathy? Or certainly there's going to be an element of it, let's say.
Yeah. No, I'm not sure.
But underlying, it could be ischemia. We got to call over
underlying cardiac function. Yeah.
And I think if it was ischemic, I think we'd be seeing the regional wall, where I think we've got kind of a global picture.
Yeah, and you do see less anteroseptal movement than infralateral. So that may signify something you'd have to look on.
You guys hear that?
No.
So Louise was suggesting that maybe that the anteroseptal or infralateral segments looked slightly different.
Yeah.
And so I'll take that. So I'll just show the picture one more time. suggesting that
Yep.
anteroseptal might not be working quite as well as the infralateral.
Yep.
Okay, yeah, I'll pay that. I think if we see regional wall motion abnormality, you've got to go and check it out. And for those segments, remember, if we're worried about that parasternal long axis, we've got 2 other views that we can look at to go and look at those walls. What are those, Ben? And I'll click on them so that'll help.
So looking at a short axis, parasternal short axis there.
So here, if I was to look all the way up, so I can look at my anteroseptal here and my infralateral here.
Yeah.
And can you see you just got a weird wobble?
Yeah, almost a bit down.
Septic cardiomyopathy, it's almost like there's almost dysynchronous contraction, and it's not well described, but in the literature. But I sometimes worry that these septic cardiomyopathies, they just look like that's a heart that doesn't look like it's contracting right to me.
Yeah.
And then the other view would be, so if you've got the parasternal long axis, we've also got what's known as the apical long axis, or as I call it, what's another word for the apical long axis?
Like a 4-chamber.
Three chamber.
3-chamber.
So yeah, nice, thanks, Johnny. So it's when if you're at it, so at the apical 4-chamber, so the knobbly bit on the echo probe is pointing down towards the bed. You rotate it 60 degrees to get your 2-chamber. You go another 60 degrees round, you get your 3-chamber, and that's often known as that the apical 3-chamber or the apical long axis. I don't have a great picture of that, but those would be the other things that I'd look at. So Louise quite rightly suggested that didn't look quite right. Maybe there's ischemia because that wall's not moving as well as the other one. My first thought is I'll go and check it out in other views to try and back that up.
Yep.
But reasonable thoughts. So I think if we've got this, I thought it was a bit more global. Louise thinks there's some regional wall in there. I think probably she's got a fair point looking at it again. But let's say it's a bit more of a global picture. The other diagnosis is that this lady's got undiagnosed heart failure, that there's some underlying principle behind it, which is where, again, just to reiterate that point that I made in the lecture, whenever it was the week before last, to say septic cardiomyopathy is a reversible biventricular systolic and diastolic disease where you can have normal filling pressure unless you fluid overload the patient, and they can have raised left ventricle and diastolic pressures for that, or you can be horrifically hypovolemic and you can have obstruction, right? That's the septic cardiomyopathy picture. But what's tricky to examine in these patients is that you don't know if this is acute or chronic.
Yeah.
Probably an acute component to it if she's this bloody sick on all this support, but we don't know. So the only way that you can see if this is septic cardiomyopathy is to support her and then do a repeat echo and see if it's improved.
Give it some time.
Yeah, you got it. So, and that's why I find it really tricky to do studies or read studies about them, because it's quite hard to define exactly what a septic cardiomyopathy is sometimes. But that's fantastic. And that's exactly that's the whole case, really, just saying, if you're on a truckload of support and the heart looks like that, there's something wrong.
I had a question, Sam.
Hi, how's it going? Is that Harvey Bay? So just having a look. Hey, how are you going?
That's rocking. I'm sorry.
Excuse me. Sorry, I keep on getting that wrong.
But you mentioned about whether it is acute versus chronic.
Yeah.
The chamber size, and if there is valvular regurgitation, then they are more likely to be chronic.
Absolutely. I think you can have a few things that will point you in there. Absolutely. If you've got some form of bad LV systolic function, you by definition would have some form of LV diastolic dysfunction, and that would give you some form of dilated left atrium. Absolutely fair comment. I'll take that. Let's have a look. Do we think the left atrium's dilated? Sorry, I don't think we've measured it, and I don't have the form in front of me. It doesn't look super dilated, so absolutely that would fit more with the chronic thing. I just wonder whether it would be, I still think I'd want to see a follow-up echo and things getting better to say that there's no underlying heart failure or any heart dysfunction in there. I guess that's all the point I was trying to make. Nice. All right, let's try another one. So on this regard, we'll have a look at this patient. Arnie, do you want to have a crack at this one? So,
sure.
Arnie, this is... So we've got a lady here who's 40 years old. 40 years old, and she's got hemophagocytic syndrome because she's got horrific underlying lymphoma. So I think it was a pretty good clinical pickup by someone that she was potentially getting really sick up on the wards, and the hematologist picked this up with her horrible thrombocytopenia and fevers and things like that. And sure enough, she fell into a heap. This is shortly after she was given some chemotherapy, and but along with the chemotherapy, a few days later, she becomes hypotensive, breathless, and ends up having some severe hypoxic respiratory failure and a PEA arrest. And we get her back for that, and we bring her down to the ICU, and this is what the heart looks like. So...
oh my gosh, you've already given me so many reasons why she could have a bad heart.
Fantastic. So, if I told you that I was doing a study on septic cardiomyopathy and I admitted this lady into the study. So that's the context about this, I guess, because, and that's, I guess, what I'm trying to get at with this little sort of segment is to say that it's hard. So yeah, with that story, I admitted this lady into my study. So tell me what you think.
All right, so there's a parasternal long axis view. The LV appears potentially dilated, but I would like to measure it.
And it is dilated. It is, what I said, it was 60 millimeters, sorry, 56 millimeters. So normal's less than 53. So yeah, it's mildly dilated.
Then the LV function is clearly reduced on that single view, I'd say moderately reduced, but I would want to see more views. I'm also not sure whether it's like optimally cut. I don't see the aortic valve there, whether to judge on regional wall motion abnormalities. At least there's some thickening, the anteroseptal wall and infralateral wall.
It's the bad projection. I took these pictures. It's got to be perfect, right?
Yeah, okay.
No, I'm kidding. It's probably bad. It's probably a little bit off.
No,
because I haven't given you everything. I just said she had a PA arrest and then got admitted to the ICU. Do you want to know anything else before you comment on the LV function?
So to share a little bit what goes through my mind, I mean, you told me she had chemotherapy. Surely she had an echo before that already to compare it to. She did she have a strain study? Even that's usually what they would do to look at that. What that would be an indication not to give the chemotherapy. What chemotherapy agent has been given?
Sorry, I've shown you the wrong.
Then there's obviously the contribution of the cardiac arrest, potential sepsis.
I'm really sorry. I've shown you actual follow-up studies. So it was even worse than that. I'm sorry, I've shown you the wrong one. So this is the study just after she came into the unit. So
yeah, right.
And here you can see the LV function is clearly down, and the point is that you just mentioned is perfect because I was able to include her in the study because I knew this was acute. Because this was done on the 29th of the 12th, and it was about a month ago that we had the pre-chemo echo study done. And
right.
I'll see if I can find you a half-decent one. Maybe that one's a bit better. Maybe not. And that's exactly right. So that we could say that a month ago, she had a relatively normal echo. She had chemo, and then she'd fallen into a septic heap from a respiratory point of view with the hemophagocytic syndrome, they thought. But this was post-chemo, and I guess this is the tricky bit where we say we've got some acute dysfunction. Is it chemotherapy? Is it infection? And the way that you can check that is to give supportive therapy, I guess, and try and treat the underlying sepsis and see if it gets better.
Yeah.
So I'm pretty sure this is, we often have multiple diagnoses that are potentially going on with these patients. Beautiful. Very nice.
And then, what type of lymphoma does she have? Is it even, cardiac and invasive lymphoma, all these things you want to think about.
And it wasn't cardioinvasive, and the chemotherapy agent they gave her was not rip-roaringly cardiotoxic. I think, it certainly wasn't one of the main ones that we get concerned about. And that's why I thought we could admit her into the study. But I think with a lot of the studies in septic cardiomyopathy, that is certainly not always clear that that degree of thought has gone into whether a patient should be admitted or not for these often small single center studies. Very nice. I might ask one more question then, if I can go back to the echo that she had when she came into the unit. So what do you say if I give you these? Tell me what you think about diastolic dysfunction. She had a mildly dilated left atrium. What would you say about her filling pressures and her diastolic dysfunction? She's got severe systolic dysfunction. So severe systolic dysfunction on a considerable amount of catecholamine support.
So you already have several confounders there. So she has impaired systolic function. So per se, you could say she has diastolic dysfunction.
Nice.
So the key question would really be to answer what is an estimated left atrial filling pressure. So the E to H ratio there is somewhere in the middle. You told me that her left atrium is dilated and her lateral E prime, she's 40, so that's definitely down. Is that 8? Measure there, 8.
Yeah, very nice.
Medial, it's also down, and her TR velocity is up. So based on that, you would say...
Dan, you're absolutely correct. Just tell me what the numbers, the cutoffs for people who are just starting off again. So for the lateral E prime...
Well, it depends. The guidelines say 10, but in a lady who's 40, it probably should be even higher.
Nice.
And medial 7, and again, in her age, it should probably be higher, and 2.8 for the TR velocities.
Fantastic.
Now, then you could say that she probably has elevated left atrial pressures, grading the diastolic function in someone who has so much noradrenaline. This is always a little bit difficult.
But even if her E velocity is 0.7, so her E to E prime is less than 15 though, can she still have elevated left atrial pressure if the E to E prime is less than 15?
I would say so. I mean, yeah. she has three criteria, and that the pattern sort of fits it. You could say that. Yeah, I mean, she would need a follow-up study to really judge on her diastolic dysfunction, but
yeah, very nice.
Yeah,
I sort of think with someone with, she'd be in the moderate diastolic dysfunction category, and even though she's not meeting all the classic criteria that we talk about, I think with the E to E prime, there's a gray zone in there, which is between sort of an E to E prime of maybe 7 or 8 and 15, where we don't really know according to the data. And that's why I quite like the new guidelines. I know they're not built for critically ill patients, but they're sort of the best we've got. I think using single parameters is sometimes not great. And so this is just that's why I like these guidelines, where we can use all of this data together to try and make an estimate of what the diastolic function is and whether the left atrial pressure is raised, yes or no. And so I completely agree with everything you said, and it's just a nice way of using all the data that you have available. Okay, I'm just going to show you one last one then. Who else have we got on the screen? Do you guys in Rockhampton want to have a go at this? Who else have we got here? We got Harvey Bay in Rockhampton. So again, just playing on the septic cardiomyopathy scheme. This is someone who's had escalating inotrope requirements. I can't remember exactly why they were septic, but this is the patient. This is only from a few days ago. I think this was a patient who we found out was immunosuppressed and had candidemia in their blood. And this was an echo because they were intubated and on escalating levels of inotrope with a high lactate, so in good going shock. And so this is again a patient who could be included in the study that I'm doing on a septic cardiomyopathy because they're meeting all the criteria for septic shock and things. Tell me what you think of this echo?
So it's a parasternal long axis view,
Nice.
and from just visual, it looks like the septum is thickened and the posterior wall looks thickened, and it looks like kissing ventricles.
Nice. What do you mean by that?
So more likely to be hypovolemia as a cause of shock for this patient, or at least a contribution for this
Nice.
patient.
What else can you look for? So take me through the next thing. So this is just a single view. What other views do you want to have a look for? What are you going to search?
So the other views need the apical fourth chamber.
Yeah, we'll start. My go-to view, apical fourth chamber, perfectly fine answer. My go-to view for looking for hypovolemia is the short axis view, because in the apical, in the parasternal long axis, you can make anyone look hypovolemic if you're a little off axis in your parasternal long axis or your apical fourth chamber, just if you're sort of imaging the side of the ventricle. It's a bit harder, I find, to mess up your parasternal short axis. And here you can see you've got near obliteration of the end systolic cavity coming through from the base to the mid. There you can see the papillary muscles sitting in there, the anterolateral and the posteromedial papillary muscles, and there's the apex. And so you can see near obliteration of the end systolic cavity size. And then I'll show you the apical 4 that you were after. Does that come through okay? Can you see that you've got that kissing ventricle sign as well?
Yes.
Anything else that we might be able to look for?
Then maybe get a subcostal view and look at what the IVC is doing.
Yeah.
And then VTI,
Yeah.
and
How about if I give you a hint and do that?
LVOT, VTI.
Yeah. How about if it's just maybe a fourth chamber is what I was looking for? Because this is what I was trying to get to. What do you think of this? So you wanted the LVOT VTI. We've kind of got the cursor sitting there in the middle of the ventricle, which is obviously nowhere near the LVOT. What are we demonstrating here?
So mid cavity acceleration. So
very nice. And what causes that? So what we're looking at here is these kind of dagger shapes, and it's almost a late dagger shape. And I'm so sorry there's no ECGs attached to this. But this is during systole. You can sort of see where diastole, you've got the mitral, the LV inflow here with the E and the A wave just at the bottom here. And so this is during systole with this late peaking dagger-shaped jet. And you said that was mid-ventricle obstruction. And that just reminds me of like if you've got a hose pipe and you sort of squeeze the hose pipe, the water out of the hose pipe goes gradually further and further and further until it stops as you squeeze it. And that's what we're seeing here, that velocity is getting faster and faster and faster and faster and faster until they just stop abruptly. And that's signs of significant hypovolemia, the interventricular obstruction. And what's important for the hypovolemia is that that is different from LVOT obstruction. The LVOT obstruction coming from, like a septal knuckle or from systolic anterior motion of that mitral valve when someone's hypovolemic or even normovolemic with hypertrophic cardiomyopathy, or if they've suddenly got a bit of a dilated right ventricle and that pushes the septum over. All of those things can cause the LVOT obstruction and the systolic anterior motion of the mitral valve. But this in the ventricle, so when you've got that pulse wave Doppler box sitting in the ventricle, seeing these things, that sort of only can indicate you've got this hyperactive LV systolic function causing some form of blockage. Beautiful. Any questions about that one?
Yeah, Sam, can I ask, on the parasternal long axis, it almost looked like on some clips that there was some caudal SAM. I'm not sure whether
right. Absolutely. So I think you do have caudal SAM. I'll see if I can zoom in a little bit. But do you think that, can I move that? I think we're just seeing it up there. I'll see if I can slow it down. I think maybe just getting some caudal SAM coming in there. But often with caudal SAM, that sometimes doesn't give you any obstruction, right? Well, I don't think we've got any of the actual valve that's flicking in systole. So I don't think we've got any anterior mitral valve obstruction, but we absolutely might have some caudal obstruction in there from the hypovolemia and the kissing ventricle sign. Does that sound Does that sound right to you?
Mm.
Cool. All right. I've spoken enough. Shall I let Louise do her thing? Stop share. I'll just pull this over so Louise can talk about this one. And I'll see if I can find you on here so you can see. There you go. So I'm hiding some of it with my screen.
Yeah, can you
Get rid of
can't
that?
minimize that, can we?
I can. There you go. And
Okay,
just click
you'll have
one
to
of
tell
your.
me who to ask though.
Oh, sure.
Yeah.
Why don't we start? Was Harvey Bay? Can you hear us, guys, up in Harvey Bay?
Yes, I can, Sam. Thank you.
Hey, no, are you happy to try and go through Louise's case? Is that all right?
Would love to.
Magic. Thank you so much.
So kind.
I'm
So kind.
Team game today.
I'm not 100% sure I'm going to be able to answer any questions though.
That's all right. We're all here
That's all
together.
right.
We're in this together. No judging here.
So this is the case of a 32-year-old man, and here's the background as we knew it when we did the echo a couple of years ago. Let me know when you've had a chance to read through it.
I've read it.
Okay. Oh, yours doesn't do that.
Oh, so you got to press this. Okay.
No.
There you go.
There we go. Okay, what do you think about this one?
Okay, so it's a parasternal long axis view. The first thing that I can see is a pericardial effusion that seems to be circumferential. It looks about 1.5 to 2 centimeters the most in depth. I'm looking to see whether I can see any signs of pericardial tamponade. I'm looking at the RV3 wall, so bouncing up and down. I can't see any obvious signs of tamponade. The RV is contracting well, and the LV, I think globally the LV systolic function is a little bit down. The valves both seem to be opening normally.
Okay, so I think I've got a still shot next.
Terribly sorry. Are you able to call Raju or Han? I'm just in the conference. Okay, thanks. Okay, thanks. Okay. I'm sorry, I'm not sure. What was the introduction to this part?
So this is a still shot of the pericardial effusion.
Okay, so that's just measuring the thickness of the pericardial effusion.
Yep. So it's up in the left-hand corner, the measurement.
So left hand, is that the depth 10 centimeters, 20 centimeters?
No, up in the left-hand.
2.4 centimeter
Yep.
thickness pericardial effusion, yep.
So what would you conclude from that?
So I would conclude that would have to be a chronic pericardial effusion he's shocked, isn't he? Sorry, from the introduction, he had an AKI and he was hypotensive. So so he's got a 2.4 centimeter pericardial effusion. I'd be looking at that suspiciously as the cause
Yeah.
of his shock.
So, but 2.4 centimeters is over 2 centimeters, which automatically puts you into the large pericardial effusion bracket, which is over 500 mil.
Mm-hmm.
So this is actually the pulmonary inflow from the parasternal long axis view. The green line that you can see is respiration. So when the sine wave heads up, that's inspiration, and when it heads down, that's expiration. What would you think about this?
So there is increased flow through the across the pulmonary valve during inspiration. So essentially, there's pulsus paradox, the evidence of pulsus paradoxus. You're increasing. This would be evidence of the tamponade of the pericardial effusion causing tamponade physiology. You're increasing your flow across the pulmonary valve during inspiration and decreasing it during expiration.
Okay, I just want to show you, just working through it pretty much the same way that you do your usual standard views. What do you think of this parasternal long axis, short axis?
Okay, so this is a parasternal short axis at the level of the mitral valve. I think the LV systolic function is pretty normal with no regionals. The RV is free wall, I can see it sort of trampolining, which suggests that the pericardial effusion is causing some collapses, some pressure impingement or collapse of the RV.
Yep. What do you think about the septum?
Actually, the septum looks flat. I think, and the septum's also. I think the septum's also moving.
What do you mean by moving?
As in moving towards the left ventricle. I'm not sure, Louise. I'm sorry.
Is it normal or abnormal?
Abnormal.
Abnormal. Okay.
Nice. Yeah.
So I got you an M mode through this. This is a bit hard to work out because you have to, if you look at the beginning of inspiration, have a look at what happens to the right ventricle and compare that to expiration.
Okay, so during inspiration, the free wall of the right ventricle is moving down, as in it's collapsing during inspiration, and then it's increasing during expiration, I think. They're looking, I don't know if you can see I'm not sure if you can see my cursor.
No, sorry, we can't.
Sorry, can't see the cursor.
No.
I suppose putting a finger on the screen doesn't work either.
I'm not sure what I'm looking at, Louise.
Okay, so when you're looking at inspiration, you take the first part of inspiration. So what you can see there is if you look at the diameter across the right ventricle, it's larger there than it would be. So it doesn't quite match, does it? But there is, so here, if we look at this one, it obviously happens some of the time, but not all the time. So here's the beginning, the reflection of the beginning of inspiration. And then there's the reflection of the beginning of expiration. Would you buy that during inspiration, the volume inside the right ventricle seems to be bigger than during expiration? It doesn't happen during every heart, every inspiratory, expiratory cycle.
Yeah.
And I tried to find the reverse, but I think it's not. So you can see here, if you're looking at the diameter of the left ventricle versus the diameter, so that's at the end of inspiration here, and then the diameter during expiration at the beginning of expiration.
Yeah. And
sometimes it matches and sometimes it doesn't. So if you take out the first 50%, then the second 50% looks better. Okay, moving on.
Great study.
So when you see this, I think that's what you thought was abnormal. What would you call that?
The interventricular septal movement looks abnormal to me. So looking at that, so that's an apical 4-chamber view. The RV actually doesn't look as big as I thought it looked on the other image, but it's sort of, but it would be, but the interventricular septum is moving abnormally.
So what does that mean?
So ventricular interdependence. So if you've got a pericardial effusion that is constricting the amount that the ventricles can fill indiastally. So when the right ventricular fills more, the interventricular septum moves over and limits the amount of filling of the left ventricle.
Nice.
Okay. So doing what we do next. So you can't really see it on the little snapshot at the top. This is the mitral inflow. And I've highlighted the ones that occur at the beginning of expiration and the beginning of inspiration from mitral valve inflow.
So the beginning of expiration, there is greater flow across the mitral valve than during inspiration. So when there is less RV filling, so during inspiration, when there is increased RV filling, that impacts on the stroke volume of the left ventricle and reduces the stroke volume, so you get reduced flow across the mitral valve.
Okay, and I worked out the numbers, and it's something like over 60% variation. What does that, in terms of the diagnosis, what does that support?
Pericardial tamponade, so tamponade from the pericardial effusion.
Okay. Now, this is the medial TDI for the mitral valve, and we've got a value of approximately, what did I say? 13 centimeters.
I'm sorry, Louise. I missed that. You suddenly went on pause for a second. What did you say? I'm sorry, Louise.
Oh, it said the medial septal TDI is 13.
I'm sorry, that doesn't, unfortunately, those numbers don't mean anything to me yet. I'm sorry.
Oh, okay. So normally it should be above 7. So it's 13. So we might need to ask, well, I'll
Ani?
no, I'll give the next one. Oh. So this is the lateral septal. You've got to take my word for it. So Ani, what do you think? Your medial septal's 13, your lateral's 10.
I'm not so entirely sure whether that's persuades me in any way, meaningful way. I mean, but you have an abnormal septal motion here. I'm not so sure. I mean, the bigger question, it seems like, so you're showing us some features of tamponade, but on the other hand, it needs to be a clinical interpretation of the whole case.
Yeah. So we have hypotension plus acute kidney injury.
Yes.
On the day before this was taken.
Yes, and a lady that has likely an autoimmune disease and some inflammatory pericardial effusion. Is she on any treatment already, or what is the progression?
So
she likely needs probably a diagnostic tap at least.
Yeah, I'm going to move on to that when we finish the echo.
Okay.
So he has actually been started on a moderate dose of prednisolone already before he came into hospital, hypotensive with an acute kidney injury. Anyway. So this just demonstrates the variation on inspiration and expiration with LVOT output. So I don't want to make you do the maths on that. We haven't got the thing.
Nice.
So Arnie, what do you think of this?
So I'm wondering whether we see as well some early diastolic collapse of the RV as we saw on your M mode. The LA, I'm wondering whether it's just strongly cut or whether it's just collapsing as well, which also would suggest decreased volume going across the pulmonary circulation.
So
I can't quite see the right atrium here.
No, we never actually got a good right atrial shot. Otherwise, I would have shown it to you. We've only got the right ventricle.
Yeah.
And left atrium also looks like it's an oblique shot. So we're getting the wall coming completely together. So it's obviously not perpendicular to what we want. So here's a still shot of the subcostal. Arnie? Yeah, I see some indentation of the right ventricular free wall, and that's early distally, so that would fit was what we just mentioned. Okay, so far everyone's been thinking that it's tamponade, or is there anything else in addition to this? Because we've certainly demonstrated ventricular interdependence, and we've demonstrated a reversal of the usual TDI results between the medial and the septal mitral valve. I mean, the medial and the lateral mitral valve.
Sorry, Louise, I missed the view, but is there any IVC pictures?
Just for you.
IVC, is that IVC?
That's the IVC. Oh, no, it
No,
isn't.
it's
No,
the-
sorry, it's hang on. There's the IVC.
No, it's not.
Sorry. I don't know why that one ended up there.
Yeah, so that's not consistent with tamponade features.
Not consistent with what, sorry?
Tamponade features.
Because it's not dilated enough.
Not dilated enough, you say?
Yeah, and yeah, it's still collapsing to some extent.
Okay, I'll buy that. But nonetheless, this is hepatic venous flow, and I'm sorry, we don't seem to have the inspiratory and expiratory waveform, which is a problem. If it was tamponade, what would you expect to see with the hepatic venous flow?
So the systolic flow fraction would decrease, isn't it?
With all the through, with respiration all the way through the cardiac cycle.
Yeah, well, good point. Probably more. So with inspiration, you would get more inflow, so only on inspiration.
Yeah, nice. Well, we're not seeing that, are we?
Well, we don't know, because somehow or other we didn't seem to have the respiratory waveform on. Yeah. Maybe we did and maybe we didn't, but we'll never know. What would be, if you hadn't seen a pericardial effusion, but you had seen this ventricular interdependence, what would be on your differential?
Can you check the TDIs again? That's the clue. Okay, so you've got an E prime lateral of 10 and an E prime medial of 0.13. That's the clue. No, sorry, say it again. Constriction, right? I think it's reasonable. I think it's really hard when you've got dual pathologies potentially going on. But that's what we're getting at? Is does anyone know what this sign is called, where the lateral is less than the medial? Beautiful. Yes, annulus reversus. And so normally the lateral E prime is greater than the medial. And there's only one disease where it's the other way around. It's meant to be pathognomonic for it, which is constrictive pericarditis. And obviously for constrictive pericarditis, to get a horribly inflamed and constrictive inflammation of your visceral pleura, you've got to have some form of exposure to something such as radiotherapy, cardiac surgery, infection. So the big one for me in this one is this infected, that pericardial effusion? Because you can get, that's known as a effusive constrictive pericarditis. Sorry to interrupt, please.
No. That's what I was going to say anyway. So the point with this is that, yes, he's got an effusion, and yes, it probably is tamponade on the clinical picture, even if the echo doesn't agree 100%. But on top of that, he has some features of constrictive pericarditis. So this is part of the echo that was taken when we were sampling his pericardial effusion. And we put the drain in. What are you looking at there? Arnie? What's shown on this shot?
Yeah, I'm not entirely sure what view this is, but you're showing me some bubbles.
Yeah.
If that's the pericardial effusion, you would confirm your positioning.
Yeah. So the drain is sitting in what we hope was the pericardial space, and we've injected some bubbles. And that's just the same again. That's about an hour later, when you can see that you can still see the bubbles. The effusion may or may not be a bit less.
Very nice.
Oh,
We've only got 5 minutes left.
That's a nice case.
Yeah, thank you,
There was
Louise.
a postscript. What did you do to my postscript?
I didn't touch anything.
Oh.
But what I might do is,
It's
if we've only
gone.
got 5 minutes left, I might ask Anne-Marie to do one more, if that's all right.
No, it's disappeared. Anyway, the addendum to this case is that he had an increase in his prednisolone, and that plus the drainage gave him a normal echo 1 month later. So it was all inflammatory constrictive effusion.
Thank you, Louise. That's awesome. We're just going to do one last case in the last 5 minutes or so. And that's for Anne-Marie, who's our wonderful echo fellow. Here you go, and that is how you make that work.
Okay. Hello. Does anyone want to do this one?
Or maybe you can make people so you can see who you're looking at. There you go. So Ben's just starting. Arnie, we smash with everything. Got Rockhampton are pretty good. Swapnil's pretty good. He pretends he's not, but he is. Swapnil, are you up for a case?
No.
Or we can have a look at Rockhampton as well. We just kind of push them. I think maybe what's the goes? Maybe would you guys in Rockhampton like to have a go at this? Sweet.
Yeah.
Yep.
Okay. This is a 30-year-old female who had an echo on Monday. She is 26 weeks pregnant and came for a surveillance echo for a known cardiac condition, and is entirely asymptomatic. So, start the next one. Do you want to start with this one?
Okay. Sam, it's actually Rockingham.
Oh, sorry guys, I'm going to get it right one of these days. It's only going to take me 6 months.
Completely
Oh,
different
goodness.
state.
Sorry, it's a completely different state.
Diagonally opposite to Rockhampton. Okay, so we have parasternal long axis view. And most obvious thing looks like the LV is very dilated.
She asymptomatic.
Hmm.
Right. Wow.
Anything else? Carry on.
But I would like to see other views to ascertain that.
Yeah.
The mitral valve looks very floppy and bit thickened as well. I don't know whether they're.
Just give us a little bit more on that. So yeah, you're absolutely right. It looks so you said it looks floppy and thickened. Just take us through a bit more. What do you mean by floppy?
So it looks like when they are coapting, maybe they are coming. There might be a bit of. Yeah.
Collapse. That's bowing as well. Bowing.
Nice, nice, nice. Yeah, what's the bowing? Take us more of that. What's the word we're looking for? There's a buzzword in here.
There are two things. Collapse and
They're going below the line of the annulus.
Yeah, nice, very nice, very nice. So they're going below the line of the annulus. Beautiful.
What's that called?
What was that?
And,
Sorry. So which leaflet is it affecting the most?
anterior.
Anterior, yeah.
Yeah, great.
Good man.
Going right to the septum.
So before I show you the colour, what would you expect to be associated with that?
Mitral regurgitation.
And in which direction?
It will be directed
Posterior.
posteriorly.
Right. So I'll see if I can.
And what's the thickening in that left ventricle near the aortic annulus? This is usually problem.
Sorry, we can't hear you very clearly if you're asking something.
Say that loud, no? Near the, it's the septal sigmoid septum, isn't it?
Yeah,
That's just the sigmoid septum. So there is mitral regurgitation. It looks like a wall hugging.
Yeah, great.
And which direction? Anterior or posterior?
Posteriorly directed.
Beautiful, beautiful. So if the anterior goes, it goes the other way. Absolutely. So it goes the other way from the prolapsed valve.
And I'm just going to go straight to here. Did you want to comment on that one?
So that looks like the regurgitant jet is possibly going right up to the pulmonary veins.
Yeah,
Looks
nice.
like a severe mitral regurgitation.
And where is it? Sorry.
Severe MR. That's why our LV cavity is so big.
Yep. So you're calling it severe?
Sorry, why are you calling it severe?
Just by the color Doppler, I would.
All right, let's just go back to the color Doppler, and we're just going to
Sorry.
play with it a little bit. Yeah, turn it down, turn it. How do you do it? Yeah, the gain, that one there. How about so we're going to play the gain now a bit. So you kind of turned it down. What do you think about the severity now?
Actually, it's, now we can't comment, but it's,
Yeah, nice.
Wall hugging.
And now I'm just going to turn the gain back up. So I'll turn the gain so it looks ridiculous. And you can make it look much worse. I guess what I'm trying to demonstrate is that the gain can get you in trouble by itself. I think you're right, but you're saying it because it's the wall-hugging jet and it reaches all the way to the back, right?
Yes.
Yeah. So
Plus the dilated LV cavity, could possibly because of could be a progressive.
But the gain is inappropriate.
Yeah. But just going by the current, what you say is right. If we change the gain, it might change our.
all right, but the other thing in the guidelines, they say that the area of the color jet has to be about 60% for it to be severe, whereas the color jet only looks relatively small. So why is that?
That's because of the wall hugging.
Nice.
Jet.
And what's the buzzword we're looking for in the exams? Wall hugging jet. Why doesn't it make more color? It's called the something effect.
Coanda.
Yeah, beautiful, good man. So yeah, the Coanda effect, and that's the effect where when you have a fluid motion, it sticks to a wall. I'm sure there's a better physics explanation for that, but that's all I know.
There's only one other thing I wanted to show, and that, what do you think of the LV function? And you can have more views, just ask for what you want.
It appears to be contracting well. The systolic function appears, it is dilated.
Mm-hmm. So it was 6.2 centimeters in the parasternal long axis for a woman.
So it's a dilated LV, but systolic function, there's no regional wall motion that I can see.
Okay, cool.
Two chamber.
Yeah. In cases he did.
I'm two with OJ. He's got a bit of fluid go.
That's the two chamber view, is it?
Yes.
So the anterior and posterior wall are moving well.
I'll just finish because Sam needs to leave. So we did a Simpsons biplane, and the function was actually an ejection fraction of 47%. So do you want to make any comment given the severity of the mitral regurg?
With the severity, yes, ejection fraction of less than 55%, it would be an indication for intervention. But you also say she's asymptomatic, isn't it?
Yeah, and 26 weeks pregnant.
What was her progression during the pregnancy so far?
This is her first echo, actually. And so we've just elected to repeat it in 5 weeks. And she's still playing soccer. But I had the same concern. I spoke to Prof and asked him to come in because I thought she needed urgent intervention because her EF was down and she should have been hyperdynamic because she's pregnant, and she should have been hyperdynamic because she has at least moderate mitral regurg. But Prof reassured me that given that she can play football, we're just going to sit tight and do surveillance.
Wow.
So her stroke volume, did you measure the stroke volume for her?
Let's go to reports.
Oh, it's
sorry, if you go here.
Stroke volume was probably normal, I imagine.
So stroke volume is 71 mils.
Common sense advice.
Yeah, so it's normal.
Yeah.
Probably the large LV is compensating for the lower ejection fraction.
Very nice.
Thank you.
Guys, well, thank you very much to Louise and Marie for presenting these cases, and thanks to everyone for joining us today. Sorry that it wasn't lung ultrasound, and that will be done in a couple of weeks by Marte Rudas. And next week, Benny Samadi will be doing the prosthetic aortic valve stuff. So see you guys next week, okay?
See you. Great. Thanks, Sam.
Thanks.
Thanks. Bye.